Well, there we are. Excellent. Back again. Thank you very much for SSF for having us here and allowing us to demonstrate. We are going to pretend that this cadaveric specimen has a fracture and that we would be doing percutaneous fixation and internal bracing. This is actually a really great use of the robot that has been very practical in my practice. If a patient comes in with a burst fracture, neurologically intact but quite uncomfortable, this is a way we can minimize the disruption to them, place hardware, let them heal, and then even electively remove it. And this has proved to be a great way to save some motion rather than having to fuse these patients. So I've been pretty pleased with it. The cadaveric specimen's already been spun and registered with our computer here. And when we look at our screen, I'm a big fan of planning these screws beforehand. Now, in a trauma situation, you are going to have a CT scan by definition. Nobody ever leaves the trauma bay without a Foley, an IV, and a CT scan. So we have our CT scan, and we can plan this. And I'm a big fan of planning outside of the operating room environment where the stress is much lower, and I can accomplish a few things. And so if you don't mind, I'm going to show a few of the things that go through my mind when I'm looking at screws. So in planning the screws, I want to make sure that my screws are all lining up in a way that it'll be easy for me to pass my rod. I also want to make sure that I'm maximizing the minimal pedicle. And particularly in osteoporotic patients, I'm going to want to engage the cortical bone of the entire pedicle. So I'm going to want to plan that to have the angles achieve that. And not everybody's built like the Netter book. And so having that CT scan and being able to see that pedicle, being able to look down the pedicle and see where are my pinch points, where is it going to be tightest. And I can also plan the space between my screws, so how far away are they going to be so that I don't end up having to do creative rod bending. And then what are the angles that my hand's going to be at? And I try to have those all match up within about 5 millimeters for the inner screw distance and about 5 degrees for the angles themselves. Once we have that, we can register. It's already been done here at the lab. Thank you very much to the lab staff. We can go on to navigating the screws. So I'm going to send the robot to its first trajectory here. And Dr. Rao was kind enough to expose the spine for us here earlier. And we are on trajectory when we're yellow. We're actually on trajectory and at depth when we are green. And we can start off with this handy tool, which is the burr. And this is just simply to make a little divot for our side cutting router to go in. As emphasized before, we really don't want to force ourselves on anybody or anything. We want to go nice and soft. We want to make sure that we're lined up. So I'm going to resend that, make sure that we're still in the green. If we need to do anatomy checks, we can do that with our instrument. And very delicately, hand's getting in the way there. We can do it. Can we have an Army Navy, and maybe I can move some of that tissue out of the way? Do we have an Army Navy tractor? Thanks. And that's just so we don't bind up on it. We don't want to pull too hard, just don't want to move things out of our trajectory. Okay. Then we can take our side cutting drill and place that into the divot that we made. And this is actually a very narrow pedicle. So I'm expecting to feel a little bit of resistance, and I can feel that. I also have the benefit of the skyvometer, which is this offset indicator there that will also help me realize when I am off trajectory. All right. Typically, I do tap my screws, and I usually do this under my own power. and that is my bicep. And in this case, when we're dealing with bone that we're considering osteoporotic, I will usually just tap enough to get the screw engaged, and then we can place our screw down into the hole that we've previously made. I cannot emphasize how important psychologically having the little check mark is. It makes us all feel a lot better. But we also trust and verify, so I do actually use neuromonitoring to check. And my threshold is generally 12 milliamps. Dr. Rao, would you like to place a screw? All right, so we're gonna move over to the contralateral side. I do start as far away from the DRB as possible, and I do a serpentine pattern to come back. And the reason I do that is that the tissues have resistance in them. And as we place the tap or the screw, we're going to pull the patient's body ever so slightly towards us. And if we do that on one side all the way down, that little bit of micromotion can actually turn into some macro motion. And we really don't want to do that. So now Dr. Rouse can look at the screen here and see, is he directing the instrument? Okay, so you're going to start off the bone. And we're just making a small divot for where our drill can go in. Go ahead, keep it going. Okay, great. Let's go ahead and move on to our drill. We got Ian working today. Excellent. All right. And then we want to have this lined up and nice and green. If we have any concern, we can, let's see, where am I going to hold? I'll go ahead and start the drill. And it really doesn't take much with this device to get down. It's really very gentle. All right, let's get the tap. And if I'm concerned about purchase, I will usually just do the very start of the hole. If I'm concerned about how sclerotic the bone is, I will tap it way down. But that allows us to have a little bit easier insertion if it's already pre-tapped. There are screws, and some companies have them, where they're sharp-tipped on the end, and I actually prefer the ones that are a little rounded. And by tapping it, it allows it to feed in a little bit easier. I also tend to like the headless screws. You've got your green, so you're validated. It's got to feel good. Because then that frees me up to do the work on decompression and such later without having the tulip head in the way. Now, if you're doing it percutaneous, you're going to need the towers. But then, of course, you're going to be doing your decompression through a different area there, as well. I do like to do the serpentine pattern. So at this point, we'll go down to the T10. And since I'm right here, I'll go ahead and do this one. All right. So we got to watch, as one of the previous speakers mentioned, we have to watch the line of sight issues with this technology. All right. And then we'll switch over to the drill. Sorry. Let's go ahead. Now let's just say at this exact moment, somebody bangs onto the arm. That's right. All we do is resend it, and it'll go right back to where it needs to go. We can move it out of the way and just put it right back. And sometimes the rechecks are just what you need to do. Get it on and reassure yourself. I would say that when I was first integrating this into my practice, I was very nervous. I was concerned about, oh, well, can I trust this? And it took me quite a while to develop that. And the way that I did develop that was I kept my practice of placing the screws with the fluoro and checking that my fluoro images were on. And after about 20 or so cases of double duting, I realized this was very reliable and consistent, and I really didn't need to have those concerns. And I stopped doing the fluoro check with every screw. I do like to see an image before I leave the operating room, and I appreciated the comment earlier that if you're going to do a revision screw, you want to do it at the time of surgery rather than later, but that really hasn't been much of an issue for us in the several cases that I've done before. I don't know if you can appreciate it there in the lecture hall, but we did use a different size screw on this pedicle because we could accommodate it. The T9 pedicle was quite a bit smaller. This one's a little bit wider, so we could get more engagement with a thicker screw. Dr. Rao, would you like to place the screw on this side? I think. One of the tricks that I have discovered the hard way is that if these reflective balls get any moisture on them, that they will send signals to you that might not be accurate. So we have to be very careful about that when we hand instruments back and forth. When I've done this technique for burst fractures, we were able to place screws above and below and then use a device where we were actually able to use ligamentotaxis to correct some of the kyphosis that was present at the fracture. Through ligamentotaxis. And then after 12 weeks or so, when the fracture was healed, we could lessen up on our activity restrictions for the patient. And then at about 6 months, in the most recent case I did, we actually electively removed the hardware, which was nice. And we followed the patient out afterwards, and the healed fracture still had some kyphosis, not the degree it had originally, but it remained at the same level of deformity, did not get any worse. And so I considered the treatment to be effective. I was very pleased with it. All right. Now, a couple tricks, please. A couple tricks about passing the rod. Just like with pre-planning the screws, if you can plan the screw heads in a way that it sets yourself up for success. If you have one screw head here and one screw head way out here and one screw head here and one out there, your rod's going to be very difficult to pass. But if you can have them generally in alignment, you're going to achieve much more success and be much more satisfied as the rod is placed. Another challenge is also the height and depth of the screws. So if you're reducing a spondylolisthesis, you're going to want the screw to be deeper and the other one to be higher so that when you place your rod, you can actually use that to your advantage.
Andrew, what other kind of techniques have you had to do for, say, the osteoporotic population? For example, I know for myself, I've tried to place some screws through the fractured level or have added cement sort of at both ends of the construct. Have you incorporated any of those techniques?
So when I was in training, Cal and I had looked at putting cement in with the screws, and ultimately we were dissatisfied with that. It didn't seem to have the impact that we had hoped that it would, and that's a technique that I've seen other people try as well, and they've had varying degrees of success or failure, but for me personally, that didn't really seem to make a big difference. What does seem to make a huge difference is engaging that the best bone you possibly can. And so I have the philosophy of, if I'm going to stick screws into osteoporotic bone, I think of it as room temperature butter, and I'm putting toothpicks in it. If I'm going to lift this off the plate, I need as many toothpicks as possible. So I will frequently add more levels of instrumentation to an osteoporotic person so that I have more purchase overall. Really engaging the cortical bones. The cortical bone just in that subchondral section underneath the disc itself, as well as within the pedicle itself. If you can capture that, your chances are pretty good. And we've heard some of the other speakers talk about maximizing your pull-out strength by going more in a lateral to medial position. And that's, I think, actually, those are all really good points and things that I try to engage in. I'm super fascinated by the presentation on the AI about where the stresses are going to be. If we instrument this level here and stop this, is this going to be a red zone? Blown away. I'm looking really forward to seeing that become a practical application for us. I think that will change the way, what level are we going to use for our final cephalad and caudate aspects of our constructs. I think it's going to be important. And then motion sparing technology. There was a period of time when we were doing repeat scolies and we would put hooks at the top in an effort to smooth that transition. Now, that turned out ultimately not to work, but ideas like that, where, can we smooth that transition into the flexible spine from the rigid spine? And, there's technologies out there that people look at, we'll see, but ultimately, one of the challenges with a rigid to flexible spine and not going into proximal junctional kyphosis or developing adjacent segment disease is managing the muscular tissue around those areas. Can we keep these muscles healthy? Can we avoid the sarcopenia that comes by doing a dissection and the pressure of the retractors against these muscles? And then how long? There's some really good data from the lateral guys that shows that the length of time that muscle is compressed has more to do with the damage to the muscle than actually how big a construct or what you do through it. And so I think that's an area where there's going to be some improvement. Let's go ahead and get this screw in here. So I think that areas that I get excited about when it comes to osteoporotic management is going to be maximizing their nutrition, making sure that we engage the best bone we possibly can, minimizing the damage to the muscles, and then quick rehabilitation. Can we get these patients out of bed and walking with physical therapy within an hour or two of the surgery? Totally off topic, but I do a lot of Duramorph epidurals, and we have physical therapy mobilize the patients, as soon as they're out of the PACU. And that builds a lot of confidence for the patients. When the epidural wears off the next day, it's frequently hard to get them out of bed unless they know that they can do it. And so having done it the night before has seemed to be really helpful. I don't expect that with the baby boomers aging that osteoporosis is going to be less of an issue. I think we're going to have to deal with this more and more.
Do you find
so it looks like we're in the green zone.
Do you find yourself in the osteoporotic population hand placing the screws so you have that tactile feedback of what the bone feels like, or you just still use the drill?
I'm sorry, I missed the first half of the question.
For the osteoporotic population, do you hand place the screws, or do you use the power?
So I actually hand place almost all my screws regardless. I think at some point I'll probably develop carpal tunnel or maybe some CMC arthritis that'll make me switch over to power. But right now I do appreciate, and it gives me a better feel of the quality of the bone when I can feel the engagement. So I do appreciate the feel. And it took me a while to learn what does it feel like going through the robot versus doing my traditional open techniques. When I first learned how to place pedicle screws, it was with an air drill. And we would, palpate down the pedicle with this air drill, tapping our way down. And that actually taught me a lot about the feel. But of course, it feels totally different when you do it with a spoon-shaped device. And then, of course, if you're doing it through a device that has some resistance, like these guide tubes that have here. So I think practice is really helpful. What's one of the nice things about this particular technology is that from a training perspective, you have the guided hand. You can work with, as we're training other surgeons or if we're working with medical students, you can give them a certain degree of freedom because you know that they're going to be in the general rate area and a little bit of supervision, but also they can see where they're going. They can process that and they can feel the sensation of what it feels like to actually go into the bone. So it is somewhat sticky. So this can be about as exciting as watching the paint dry, but it's generally a very short period of the case, and most of the time is going to be spent doing what you came to do. We've gotten to the point now with an experienced scrub tech and radiology technician, and I use physician assistants, and that the hardware placement's actually the least stressful, fastest part of the case, especially with the preoperative planning. So it's actually become interesting to me that we spend a lot of time learning how to do this kind of surgery, as far as placing instrumentation and where do you place it and think about that. Actually, I spend most of my time in the OR now doing decompressions and deformity corrections, which is very satisfying. Okay. I think, if there's any questions about this technology or my approach to its adoption, now's a great time for me to entertain them while we're placing the last screw here. Does anybody have anything for me?
Yes, Andrew, Pat Johnson. I love, your first premise of this illustrative case was that of a trauma fracture problem. And, this is just incredibly good technology. When you have a patient with a chance fracture, you have something that's, not really dislocated, problematic, and you just need to fix it in position. And, the percutaneous placement of rods. I mean, I'm acknowledging, the value of not just navigation, but I think the robotic, it's a great place for it. I mean, it really is that I think this changed the trauma world, and there's been so much published about it. I mean, I think it's pretty well accepted, and it's great technology, and I think, the robot's a place that it actually makes lots of sense for those particular cases. You've, touched on all kinds of other pathologies, but, your single level fracture problem, ideal case.
Yeah, I absolutely agree. Chance fractures, what a great case for this technology. That's that, and yeah, I appreciate that. That's absolutely true. I have found it to be very helpful in the deformity, and Dr. Kent, who was mentioned earlier, has really pushed the envelope in what we can do with deformity corrections. And I've found that this technology can be very, very useful in that, particularly because you can plan your corrections and execute them with consistency and pretty quickly. And he's shown that you can do a lot of it percutaneously. I'm still doing a fair bit of that open. But even then, how you arrange your screws, the depth, the width, and the rotation can influence what the ultimate outcome is. And there's a lot of software now being developed that go ahead, that allows that to be more reproducible, even by other surgeons. And I've said at other conferences, and I still believe now, that this technology can make good surgeons really great. It can also make average surgeons better than average. It kind of levels, it brings the rising tide raises all the boats. And so I can see a world where these enabling technologies, the navigation, the robotics, and even AI can help us almost like bumpers, keep us from getting into the outlier cases. And that's been shown very effectively in the total joint population with the adoption of robotics. I think in spine, there's just a lot of variability, and that's why we're not seeing as consistent result like that in the literature. But I imagine as these continue to evolve and be adopted, that we'll see more and more of that. Well, Dr. Rao, excellent job. I see 4 perfectly placed screws here on his side. And of course, mine pale in comparison. Congratulations, nice job. And best of luck to you on your fellowship. I think we have lunch in order, and I will be circling around, be happy to take any questions. And from the online audience, please text them in and we'll answer them.
Thanks, Andrew.
Great job, Andrew. Great demo. Thank you. And, let's break for lunch.